listen to this presentation. Um, it's going to be focusing on the signs, symptoms, and treatment options for erectile dysfunction and stress urinary incontinence. I want to thank Boston Scientific for sponsoring this talk. Hopefully it'll be very informative. I guess next slide, please. So just some kind of bookkeeping we have to take care of. You can see what's written on the slide. I also want to encourage people, there is a chat function at the bottom. So if you have any questions, you can write them in the chat box and they will be anonymous, and I will answer them either during the presentation or at the end. Yeah, thank you so much. So my name is Robert Segal. I'm one of the urologists with Chesapeake Urology. I look a little different than my picture there, but it is COVID after all. I am based out of the Towson office on the GBMC campus, and our website and phone number is listed there. All right, so we're going to first talk about erectile dysfunction and so kind of what is involved. So what is it, who has it, and what causes it? So the definition of ED is the inability to achieve or maintain a satisfactory erection for penetrative sexual intercourse. It's very common, and the risk goes up as men get older. And as you can see, tens of millions of men in this country alone are affected, and it's hundreds of millions of men around the world. Next. So basically what an erection is, it's the brain, stimulates nerves that supply the penis to allow for increased blood flow to the penis. And as the blood flows into the penis, it gets trapped in there, which is what causes you to keep a rigid erection. And basically what happens, it's written down there that the veins that drain the blood get blocked by these by the blood that flows in, so that the erection remains until hopefully men can climax and complete. Next. So there's a variety of health issues that are associated with erectile dysfunction. Firstly, it's important to know that there are some men who don't have any of these risk factors who, just as they age, can develop issues with ED. It could just be that the arteries that supply the penis that need to relax and dilate to accommodate more blood flowing to the penis, they just get stiffer as time goes on, and so they cannot accommodate that increase in blood flow. The most common cause of ED is vascular, or you're not getting sufficient blood flow to the penis, and that can be associated with various risk factors: high blood pressure, high cholesterol, coronary artery disease, being a smoker, diabetes. Diabetes is unique because that can actually affect the erections in a variety of ways. Diabetes can also negatively affect nerve function. And so if the nerves that are supplying the penis don't work as well, then they won't get as good of an erection. It's not uncommon that certain medications can affect erections. And then certain other conditions, prostate cancer treatment being a very common one, either surgery to remove the prostate or radiation to treat prostate cancer or other pelvic cancers is a very common cause. Next. It probably goes without saying, but erectile dysfunction can have a very negative impact on quality of life, not only for the patient, but also for the partner as well. And you can see it's certain ones are listed here: mental health, social functioning, role limitations, vitality. So it's very common that both the man and the partner are negatively impacted by this. So erectile dysfunction and diabetes. So I kind of just alluded to this briefly before. Obviously, many men, both in this country and worldwide, are diabetic. And it's very common to have sexual dysfunction once you have become diabetic. it can not only affect the erections, it can affect orgasm sensation or ejaculation. And erectile dysfunction associated with diabetes is actually considered to be more complex or difficult to manage ED. Okay, this is a very important slide. ED may be a symptom of diabetes, and this can actually also, this holds true for coronary artery disease as well. You can develop ED as a precursor to some of these conditions. So for example, men who come to see me who have never seen a doctor before and their only complaint is about their erections, I'm telling them they need to find a cardiologist or their primary care doctor to get their heart checked, because the same process that affects the arteries that supply the penis will affect the arteries that supply the heart. The arteries that supply the penis are a lot smaller and they get affected earlier. And there are some studies that show that ED can be a predictor of having a heart attack, and it can happen even a couple of years prior to the onset of heart issues. Next slide. Okay, so factors that may increase in men, ED in men with diabetes. So age, and again, that's just because age in general is associated with ED. As you get older, the risk for ED gets increased. Diabetes duration, poor glycemic or sugar control. This is all very important. And so when I see men, who have ED and are diabetic, I'm talking to them about optimizing their sugar control, not only to help the erections, but also for their overall general health. Next. So men with diabetes are at higher risk of heart disease. I had alluded to this before. Next. ED and heart disease. So I may have kind of jumped the gun here with some of this information, but it's just reinforcing that ED can preempt or can be a precursor for heart disease. Next. And yeah, so again, I'm just kind of reiterating myself. Risk reduction. Okay, so you may reduce your risk of ED by improving your heart health. And that is totally true. It's very important to, eat well, exercise. If you're overweight or obese, lose weight. If you're a smoker, quit smoking. Stress reduction is also very important. I try to tell my patients that, when they come to see me with ED, all of these things are very important. And I have definitely seen men, when they lose weight or when they quit smoking, that their erections do improve. But this is not necessarily the only solution. It goes back to how long you've had these other conditions, how well controlled they've been. Because as time goes on, if you've had poorly controlled diabetes for a long time, then the damage kind of accumulates, and you may not be able to reverse the dysfunction as readily. Next. Okay, erectile dysfunction and low testosterone. So low testosterone, otherwise called hypogonadism, is when your body does not produce enough testosterone to help you function normally. Testosterone is the main hormone in the man's body that gives a man his vitality. It allows him to function normally sexually. They have, it gives them libido or sex drive. It gives them energy, the ability to exercise, and erections are part of this. And as men get older, testosterone can decrease, and low testosterone is associated with a lot of these other conditions that I've already referred to. So diabetes, high cholesterol, high blood pressure. So men who have these things are more likely to also have low testosterone. Next. Excuse me. Just go back for a moment, please. Again, just to reaffirm this as well, some of the signs and symptoms of low testosterone: fatigue, low energy level, the inability to exercise, loss of body hair, increased body fat, hot flashes or sweating, feeling moody or depressed, and then low libido and possibly erectile dysfunction. Next. So low testosterone, as mentioned, is pretty common. It's diagnosed with uh, blood tests as well as having the symptoms. And this is something that me and my partners at Chesapeake Urology do a lot of in terms of diagnosis and treatment. There are a variety of different treatment options available that we can talk about. So testosterone topical treatment like gels or patches. There are pills, there are injections, there are subcutaneous pellet implants. So there's a variety of options to treat this, which may or may not help concomitant erectile dysfunction. Next. All right, so now we'll focus on prostate cancer treatment. So the prostate is an organ that sits right under the bladder and right above the urethra, right kind of dead set in the middle of the pelvis. And it's the organ that is the most commonly, it's the most common cancer in men is from the prostate. And fortunately, there are a lot of good treatments, whether it be surgery or radiation as the primary ones. But unfortunately, prostate cancer treatment can impact on quality of life issues after treatment. And it's just because the prostate is in a very sensitive area close to other very important organs. The nerves that control the erection run right along the prostate and can be injured or damaged as a result of treatment. And that's one of the main reasons of how men with prostate cancer develop erectile dysfunction once they're treated. Next. So sexual dysfunction and erectile dysfunction in particular is very common after prostate cancer treatment. It really depends on the study that you read and how erectile dysfunction is defined. But in one study, up to 85% of men after having had prostate cancer surgery, for example, will not get back to their pre-treatment level of functioning. Next. Erectile dysfunction and Peyronie's disease. Okay, so Peyronie's disease is a scarring condition of the penis that results in an abnormal curvature. So you can see in the cartoon image on the screen that fibrous plaque is a scar that forms that makes the penis bend when obviously it shouldn't. And this can not only affect the ability to have normal penetrative intercourse, but it can also be associated with erectile dysfunction. The main mechanism of that is how it is basically when I refer to the erection, how it develops before. So those veins that trap the blood in the penis, when you have a scar like this, it can impact on the penis's ability to trap that blood. And that's called veno-occlusive dysfunction. And it can be characterized clinically by men telling me, I can get an erection, but I can't keep it, or I can get a full erection, but it doesn't get totally hard. Next. So ED can be related to Peyronie's disease. It may not be. I see a lot of men with Peyronie's disease who may have pre-existing erectile dysfunction prior to when that deformity developed. Or you can have men with Peyronie's disease who don't have any issues with rigidity. Their main problem is the curvature. Next. There's a variety of treatment options for Peyronie's disease. The only FDA-approved medication for this is something called Xiaflex, which is an injection into that scar tissue in the penis that can help soften it. And with a variety of exercises, the penis can get straight. We treat a lot of Peyronie's disease in my practice, and I do a lot of Xiaflex. So that's a good treatment. And then there are different surgeries that we can do, including penile implants, which is something that I'll get into shortly. But certainly if guys have both erectile dysfunction and Peyronie's disease, it may be a very good option because it addresses both of these issues simultaneously. Next. All right, erectile restoration treatment. So who can treat ED? It can be the primary care physician. And they will probably be limited to treating men with the pills like Viagra or Cialis or the generic equivalents. If men have low testosterone, sometimes the primary care doctor will manage that. But not uncommonly, patients to treat the problem in its entirety, or if they have tried the first line treatments like the pills without success. And then certainly a prosthetic urologist is someone who specializes in the surgical management of ED, and of which I am one. And so I'll get referrals from some of my partners even who have tried patients on non-surgical treatment without success, and then they come to me to talk about the surgery. Next. So what are the different treatment options? I'll kind of go through all of them briefly. So oral medications is the first line therapy that are very commonly known. Injection treatments, vacuum erection devices, urethral suppositories, and then finally surgery for the penile implants or penile prosthesis. Next. So the pills, the category is called PDE5 inhibitors. It stands for phosphodiesterase 5 inhibitors. So how they work is they basically improve the ability of those arteries to relax so that more blood can get to the penis. They can be taken up to an hour before surgery, sometimes even earlier. And sorry, not surgery, sex. My apologies. And they generally work pretty well. And even in more complex patients like men after prostate cancer treatment or men who are diabetic. Next. They can be associated with certain side effects, headache, facial flushing, nasal congestion, stomach upset are the common ones. There can be certain interactions with other medications. The big one being anyone who is on a nitrate, for their heart, like nitroglycerin, that is a contraindication. You cannot be on these medications if you take that. Next. Okay, so the next option is the vacuum erection device. So you can see kind of in the cartoon there what it involves. It's basically applying this device to the penis, which when activated creates a vacuum so that blood gets drawn into the penis by the vacuum. And then typically what happens is men have to use like a tight tension ring at the base of the penis to keep the blood trapped in there so that they're able to function. It's a treatment option that, I'll be honest, I do not use much. It's generally pretty cumbersome. It can be uncomfortable. Some men like it. It allows them to function without needing medications. But it's not without its limitations. Next. Just to focus on the vacuum device. One more slide. You can get bruising or numbness or coldness of the penis. Very often these are not covered by insurance, and so patients are paying out of pocket for them. And it's certainly cumbersome and without spontaneity. Next. Urethral suppository. So this is basically, it looks like a little piece of rice that you put through the pee hole that gets absorbed through the urethra. And it can work when, pills or some of these other options don't work. And it allows you to, function normally. But again, it's not without its problems. There can be discomfort. One of the common side effects is pain or kind of an achy feeling of the penis. Sometimes if the pellet does not get absorbed effectively, it can actually be thrust into the partner, and then the partner can get pain. The other issue, again, for this is cost. It's typically not covered, and I've seen it sometimes as much as $50 a suppository. Next. So this is intracavernous penile injection. So basically patients learn how to inject their penis with a medication that they would do every time they want to have sex. To me, this is probably the best of the second line treatment options, or I should say at least the non-surgical options. just because you still get a fairly natural erection. No one is thrilled about having to inject the penis. It can hurt, even though it's a small insulin type needle. Patients are weary of it. It can hurt, and it can be associated with bruising. And again, it's also not very spontaneous. Next. All right, so we get to the definitive treatment here, the penile implant or penile prosthesis. So this is the surgical implantation of a prosthetic device that goes in the penis that allows you to have an erection basically whenever you want. I'll go through this, I guess, slide by slide. The good thing about this device is that, and this has actually been studied, it has the highest patient and partner satisfaction. And I think a lot of it has to do with it's very reliable. You know the type of implant you're going to get every time. And it also allows you to be pretty spontaneous. Once the patient is comfortable cycling the device, it takes, maybe 30 seconds or a minute to pump it up, and then you're ready to go. Okay, so here we go. This is good. So this is the different type of devices. I'm going to focus on the device on the far right, which is the 700 series. So that's considered the 3-piece inflatable device. This is considered the top of the line, or the Cadillac, so to speak. So how it works is you have these 2 cylinders that go in the penis. They connect to a pump that sits in the scrotum between the testicles, and then also connecting to a little balloon that goes up in the pelvis or abdominal area that patients can't feel or see or anything. And so they're able to walk around with a regular soft penis that, like they normally would. When they want to get an erection, they feel for the pump and they pump it up, and that causes the fluid to transfer from that balloon up in the belly into the cylinders in the penis. So you get an erection, and then you're able to keep it as long as you want. And when such time comes as they don't want the erection anymore, they feel for the deflate button that's also in the scrotum, and then that causes the fluid to transfer back into that reservoir. So it's pretty subtle. People, just by looking at the person, wouldn't know that they have this. So I always tell my patients, if you're showering at a health club or something, no one would know that you have it just by looking at you. There's no metal in these devices, and so if you go through a metal detector, it won't beep. If you need an MRI, it's totally safe. So these are really ingenious devices that have kind of transformed managing men with erectile dysfunction. The other 2 devices, I'll just say for the sake of completion, the Amicor is a 2-piece device. Basically what happens here is you just have the cylinders and the pump, and there's no intra-abdominal reservoir. And so it's very rare that these devices are put in. They're not as good or as rigid as the 3-piece devices. If someone has a condition whereby they cannot have any foreign bodies or something in the pelvis or in the abdomen, then this is an option. And then the final option is the Spectra, which is what's called a semi-rigid device. So basically you put these 2 rods in the penis such that the man kind of always has an erection, and you kind of bend the penis up when you're going to have sex. Otherwise you bend it down, and you walk around with kind of an erection all the time. It's, again, rare or not common that we use these. These may be good in someone who does not have manual dexterity, so someone who's had a stroke or Parkinson's disease or some neurological condition, or they just don't have a lot of hand strength. There was a question in the chat, do men ejaculate with these devices? And the answer is absolutely. So these implants really are meant to function with so all they do is replace an erection, or they give you means to have a rigid erection without needing any of these other treatments that I alluded to before. It does not affect orgasm. It does not affect ejaculation. It does not affect length of the penis, sensation, nothing like that. So if men are intact functionally, prior to the implant than they will be so afterwards. Certain conditions like diabetes, for example, can affect ejaculation, or guys who've had prostate surgery, ejaculations can be affected. So if you have issues before the surgery, the implant won't restore that. Another question from the gallery here: can the penis be made larger by an implant? The answer is no. When we do the surgery, we measure the penis, what's called stretched penile length. And so we put in the biggest device that fits. So if the penis measures 20 centimeters, let's say, we are putting in a 20 centimeter device. We cannot oversize you, because then it won't sit well. You will have chronic pain, and you won't be happy. So there's no study that shows that men lose length with putting in an implant. There's some conditions where length can be lost. Again, prostate cancer surgery, diabetes, radiation, just as examples. They can lose length. And so it depends what the patient is comparing to. If they're comparing to how they were, when they were 25 years old, then yes, chances are they will have lost some length. But there should not be a loss of length from, after the surgery to just before. There's another question here: how long do implants last before they need to be replaced? Excellent question. These implants are generally pretty durable. About 80 to 90% of these devices will still function after 10 years. So you do get pretty good longevity out of them. If they do break or malfunction at any point, then they need to be replaced with surgery. If the men is no longer sexually active, then we would probably defer any other surgery. But certainly, if they're still active, then that is what we do next. Another question: does insurance cover penile implant surgery? The answer is, for the most part, yes. Medicare does, for example. Most of the commercial insurances do. There are some insurances that do not. So the way our practice functions is, if we book someone for a surgery, we run it through their insurance before proceeding to surgery to make sure that it's covered. And because if it's not, then obviously the cost falls to the patient, and it's typically very expensive. All right, there's one other question here: how big is the incision for the implant? So that, typically it's, no more than a couple of centimeters. There are different strategies or different approaches that one can employ to put the implant in. There's a common approach is called penoscrotal, so the incision is done in the scrotum. There's another approach called infrapubic, where the incision is made just above the penis on the body wall. How long is the surgery? So it typically takes anywhere from an hour and a half to 2 hours, more or less. It's usually outpatient surgery, so we send patients home typically the same day, and they recover at home. Recovery is about 6 weeks until they're fully able to use the device. It can be shorter, and sometimes it can be longer. It really depends on the situation. It's not uncommon that men have pain after the surgery. Excuse me. I have some men who don't take any painkillers. I have other men who are, very much dependent on narcotics for a few weeks. So it's anywhere within that spectrum. But typically by 6 weeks, if you're fully healed, that's when we can show you how to use it, and then release you to activity. Okay, Sarah, go to the next slide, please. Okay, there we go. Okay, so the AMS device, or Boston Scientific's device, is impregnated with an antibiotic surface or coating that very much lowers the risk for infection, which is probably the worst or the most feared side effect of this surgery. I'll come to that in a moment. There are two different types of cylinders. The CLGX expands both girthwise and lengthwise. There are certain situations where we would prefer just the girth expansion. So for example, in someone with Peyronie's disease. Next. So how the device works, this video may, let's see if the video works. But basically, as I mentioned before, men feel for the pump in the scrotum, and then they pump it up. And here we go. So as they pump it up, it causes fluid to be transferred from that reservoir into the cylinders in the penis. So you can see that the erection is they want to get rid of the erection. They hit the deflate button, and the fluid gets transferred back into that reservoir. Next. All right, so this talks about, and this again is just kind of reiterates what I had alluded to before, very high degree of satisfaction for both the patient and the partner associated with this surgery. Next. All right, so the benefits of the implants, again, it's considered the definitive treatment for ED. It allows you to be spontaneous, it's reliable, everything is internal, and so it's pretty inconspicuous, associated with high levels of satisfaction. And they've been around for more than 45 years. The first implant was actually put in 1973. Next. So I alluded to this before. So most insurances do cover this. Even if there is an out-of-pocket expense to the patient, Boston Scientific can sometimes offer some variety of help with that. So it's very it's rare that that the patient cannot get this because of insurance coverage. Next. Okay, if you're a veteran, then again, you might be able to get this without issue. Next. All right, so this kind of alludes to different surgeries, or sorry, the risks. So I alluded to before the risk of the device malfunctioning. I also alluded briefly to infection. So infection is a big concern because, as with any device that gets implanted, if it becomes infected, then really the definitive treatment is surgery to remove it. And that would be the case with any orthopedic implant or heart valve or anything like that. Next. All right, so just in summary, ED is very common. There are a variety of treatment options that you would have to kind of figure out for yourself and in conjunction with your partner and your doctor, which is the best treatment option for you. Next. All right, so we're gonna kind of switch gears here, and I promise that these are great. They're great questions from the chat, so I'm gonna come back to those. I just want to make sure we give enough time to the incontinence part. So what is it? Who has it? What causes it? Male stress incontinence. Next. Okay, so male incontinence is basically undesired bladder leakage or urine leakage. And it's basically when, it's typically most common after prostate cancer removal via surgery, radical prostatectomy. So it's basically when the sphincter that normally would keep the urine inside is damaged. And so men leak when they exert themselves. So when they laugh or sneeze or cough or lift something heavy. So anything that increases intra-abdominal pressure. It's pretty common initially after radical prostatectomy, although most men heal within weeks to months. And again, the final kind of prevalence of this depends on the study. It may be as high as 15%. It may be as low as 3 to 5%. Next. So again, when this is very brief, when men urinate, the bladder stores urine so that it gets evacuated at a socially appropriate time. When you want to urinate, that's when the sphincter muscles relax and the bladder squeezes so that the urine comes out. Next. Next. So again, I kind of talked about this. Next, that this may also, have a very negative impact on quality of life, as you can imagine, perhaps even more so than erectile dysfunction, because, men with erectile dysfunction, they may have sex once or twice a week, or maybe 3 or 4 if they're very lucky. But men are leaking urine potentially all day, every day. Next. Okay, so, and again, this is very much related to prostate cancer treatment. And again, the same nerves that control the erections are important for sphincter function. And if those nerves get damaged, then the sphincter may not recover. Next. Okay, so again, I talked about how it's not uncommon immediately after treatment, and it gradually does recover in most men. But for those who don't, there are a variety of different treatment options. What's listed here, I will tell you, these are not necessarily treatment options. So reducing fluid intake is not a treatment, and that's frankly not recommended, because if you dehydrate yourself, you're going to be in big trouble. Coping methods like pads or diapers or penile clamps, again, not a treatment. This is a way of dealing with the leakage, but it doesn't actually change anything. Pelvic floor physical therapy or Kegel exercises, these are exercises that all men who are going to have their prostate removed should do, because this can accelerate recovery of leakage after the surgery. And again, in most men, this is sufficient, but in some men, it's not. Next. Uh, okay, I mean, I don't have to talk about how pads are a nuisance. They're costly. They may absorb the urine, but they can be associated with leakage or smell, skin breakdown, rashes, that sort of thing. Next. All right, so the definitive treatment options for men after prostate cancer surgery who have persistent leakage are surgical. And there are two options. One is the male sling, the other is the artificial sphincter. The male sling is meant for less severe leakage. And what you do in that surgery is you put in a mesh that basically supports or reinforces the urethra so that there's less leakage. The advantage of the male sling is that it allows you to urinate naturally. So you just, when you go to the bathroom, you pull down the pants and you let it go. The artificial sphincter is the treatment option that's definitive for more severe leakage. And this is a prosthesis not unlike the 3-piece inflatable penile implant, and I'll show you on the next slides what's involved. Next slide. Okay, so we'll focus on the male sling first. Again, this is very commonly used. You can see in the cartoon how that mesh kind of reinforces the urethra so that it actually kind of lengthens it, so it increases the resistance against which the bladder has to force, so there's less leakage. Next. It's considered a minimally invasive procedure. It takes usually an hour to an hour and a half. You go home the same day. Typically, you keep a catheter overnight, and then it comes out. And then you'll know, you get improvement pretty quickly. Next. All right, so here's the artificial sphincter. So this is a good diagram of what's involved. So you can see there are 3 pieces. There is a pump that sits in the scrotum, connects to a cuff that wraps around the urethra, kind of like a lifesaver, and then a balloon that also goes in the pelvis. And so that cuff around the urethra is squeezed shut at all times, except when you want to urinate, what you do is you squeeze that pump, and that causes that cuff to open so that the bladder can squeeze the urine through, and it gradually repressurizes over 1 to 2 minutes so that it's closing the urethra again, so that the so that there's no leakage. So it's a really ingenious device. Next. Illustrate how this works. So you can see here that the patient is squeezing the pump so as to be able to urinate. So that cuff opens up, and then the cuff gradually will repressurize so as to squeeze the urethra shut. All right, again, very high patient satisfaction associated with this device. This is really a game changer. So for men who are wearing 5 to 10 pads a day, if they can go down to 0 or 1 pad a day, they are usually beyond thrilled. Next. So the benefits, again, it allows you to achieve continence even in very severe situations. It's subtle, everything's internal, high patient satisfaction, and it can help restore normalcy and renew confidence. Next. And again, Chesapeake Urology, myself and some of my colleagues who specialize in this sort of surgery, we have a lot of experience with it. And, again, we have to decide together what is the best treatment for you. Next. So again, surgery is never without risk. The male sling, you may not get. With both of these devices, perhaps the worst outcome would be if you don't achieve the level of dryness that you were anticipating. It rarely happens in the male sling that men get urinary retention and they cannot urinate. Pain and irritation at the wound site is pretty common. But generally, the male sling is very well tolerated. The artificial sphincter, this is a hydraulic device, so it can malfunction and may require surgery down the line to fix it. The other thing that can happen is you can have kind of mechanical failure, so to speak. So that cuff that is always kind of surrounding the urethra, over time, the urethra can become thin. And so even if the device is still working, it may not cause as much tissue coaptation or squeezing of the urethra because of that. So sometimes you have to do surgery to address that issue. Next. Again, these devices are typically covered by insurance and Medicare as well. I'd say these are probably more likely to be covered than the penile implant. I mean, the penile implant, maybe 95, this is just a guess, or in my experience, maybe 95% of insurances will cover this. I have never, to my recollection, have a patient not had the artificial sphincter not covered. Next. Okay, same thing with the veterans. So in summary, again, male stress incontinence is a pretty common side effect after prostate cancer treatment, and though it typically recovers in a small proportion of men, it does not. And nevertheless, be that as it may, there are a variety of treatment options that can help address the issue. Next. All right, that's just safety information. I think I'm going to go back to the chat session and address some of these great questions. So I'm going to go, I answered some of them from the beginning, but let me just go through this. All right, there's one question. Are ED medications safe for a patient on antidepressants? And the answer is yes. Depression can be a difficult thing as it relates to sexual function or erectile dysfunction, because obviously if the condition goes untreated, that can adversely affect those functions. But sometimes the medications may also, or the treatment for depression or anxiety can also negatively affect sexual function as well. So it can be sometimes a bit of a balance, and having to confer with the primary care doc or the psychiatrist to determine the best way of managing this. All right, so moving along here. Sorry, so some of these questions I have already addressed. With the assortment of pills used for sexual dysfunction, is one better than the other? The answer is no. All the pills, and there are 4 commercial PDE5 inhibitors available currently. There's sildenafil or Viagra, tadalafil or Cialis. There is Levitra or Vardenafil, and then there's Stendra or Avanafil. They're all considered equivalent in terms of efficacy, in terms of risk for side effects. So I hope that answers that question. So there's a question, what affects the thrust of the ejaculation? So that's a good question. So typically when men ejaculate, what happens is the bladder neck, or the kind of the area between the bladder and the prostate, squeezes shut, and that propels the ejaculate outward. In men who are on medication for the prostate, like an alpha blocker, such as tamsulosin or Flomax or uroxetrol or alfuzacin, those muscles relax and they cannot squeeze shut. Alternatively, men who've had prostate cancer surgery, like a TURP or a PVP laser prostatectomy, the prostate has been cored out, and so even though the muscles are working, the bladder neck does not squeeze shut, and thus men may not ejaculate. All right, moving on. These are all excellent questions. What percentage of men cannot take Viagra due to side effects? It's not that common. I'd say most men, and I don't know that I can absolutely give a percentage, but most men, it's very well tolerated without any side effects. There are some men who have side effects that are bothersome but are not prohibitive. And then there are some men who, get terrible headaches or terrible sinusitis or something. And so those guys just cannot take or tolerate the medication. And then, you come to me or one of my colleagues and we talk about the alternatives. So we did talk a little bit about the infections because there are some questions here about that relating to the implant. Fortunately, the risk is only about 1%. And it can be higher in certain patient populations, such as men who are diabetic, men who have had prior implants before. They may be at higher risk for infection. I'll read a comment here from actually one of my patients who is also an advocate for Chesapeake Urology. The implant is a game changer. I experienced a lot of pain, but it works great. I had it installed 2 years ago. And so, he's obviously very happy with it. All right, moving on. Are there natural remedies to increase testosterone? So the answer is no. The most important way of boosting natural testosterone is going to be weight loss. The more fat tissue you have, the lower your testosterone is going to be. So that's really the best way of doing that. Okay, let me move on here. Okay, is there limits to physical activity such as biking with any of these treatments? Excellent question. The answer is no. If you're recovering from surgery, then we don't want you to do a lot of physical exertion. But once you're recovered, there is really no restriction with any of these activities. Next, can the body reject a penile implant? The answer is no. So the penile implant, or any time, even with the artificial sphincter, you implant one of these devices, the body grows this kind of tissue or rind around it that kind of walls it off from the rest of the body. So the answer to that is no. There's an excellent question. Can you discuss shockwave therapy for ED? I certainly will. This is not considered an FDA-approved treatment, which is why it wasn't part of the presentation. But there is a lot of evidence for it. So what it is, it's sound wave application to the penis. So much like we use ultrasound to break up kidney stones, it's the same strategy or same technology. And so over time, when you stimulate the penis with these ultrasound waves, it makes new blood vessels. So you grow new arteries that can help supply the penis. There is a lot of data out of Europe, out of Israel, that supports this use. It's not currently FDA approved in the United States. And so we do offer this treatment, but unfortunately, because it's not FDA approved, patients have to pay out of pocket for it. And there are certain men who I think are good candidates, those guys who respond to the pills, who don't want to take pills, those guys who respond to the pills but who have side effects from it or from them. Those are good candidates. We know certain patients are not good candidates for it. Those men who are diabetic, it may not work as well. Those guys who have had pelvic radiation or prostate cancer surgery, it does not work as well. So I hope that answers that question. Next, I understand Flomax, which is a treatment for a medication for benign prostatic hyperplasia, can cause retrograde ejaculation. Is this harmful? Good question. The answer is no, it's not dangerous. The purpose of ejaculation is to conceive children. So it would really only be harmful if you're trying to actively conceive. I will tell you, though, that a lot of men are bothered by this inability to ejaculate. Fortunately, there are a variety of treatments. And again, this is a treatment for benign prostate obstruction. But there are a variety of treatments that we have that will actually preserve ejaculation and improve urination. All right, next. Okay, our patient advocate has just made a comment that he had used all the treatment options for ED and he felt the implant was best. All right, here's another question. Are you able to engage in running with the implants without the implant hitting against the testicles? Absolutely. In fact, when you put the device in, even though the pump is in the scrotum, it's not in direct contact with the testicles. So again, there is no restriction with these devices once you are fully healed. Okay. Okay, here's a question. Okay, so there's actually a patient of mine here who's asking a personal question, so we can talk kind of offline about that. Okay, so next question. Can a Foley catheter be placed on men with a penile implant? The answer is yes. We don't love it being in for too long because then there's a risk of infection or erosion. But certainly in guys, if you're having a knee surgery and you need a catheter for, a night or something, that's usually not a problem. Next question. You mentioned that you don't prefer the vacuum erection device. Do you recommend medication like Cialis if that works versus the VED? So it's not that I don't prefer it. That doesn't mean I don't offer it to my patients. I just think it's cumbersome and it's not spontaneous. I try to put myself in the patient's shoes, and I just think to myself, if I needed the vacuum erection device, I don't know that it would be the number one option for me. I think in general, we try to go with the least invasive approach first, which is usually the pills. But again, there are some men who either don't tolerate the pills or they cannot take the pills. And so then we work with them to come up with a treatment that does work. Okay, there's a question here about testosterone replacement therapy. What are the dangers of, what are the dangers of testosterone replacement therapy? It's a good question. There was a study done or a couple of studies 5 or 6 years ago, for example, that alluded to potential cardiovascular risk, higher chance of heart attack or stroke with testosterone replacement. Those have been disproven. Testosterone replacement in that regard is considered safe. There are, in fact, a lot of studies that show that men with low testosterone may be at higher risk of cardiovascular complications, and that risk may be lower when you put them on testosterone. There's a common misconception that testosterone causes prostate cancer. That is absolutely not true. we do take precaution in men that we know have prostate cancer, because testosterone can be it's like a fuel for prostate cancer cells. But so, it's incumbent upon us to ensure that men do not have prostate cancer before we put them on testosterone. But if they go on testosterone, they are not at any higher risk of forming prostate cancer. So those are probably the two big questions. There are some other risks that it can be associated with sleep apnea. That's almost more theoretical than anything. So if men have sleep apnea and they're treated for it with a CPAP machine, then being on testosterone is considered safe. There's a next question. If you have a heart condition, are you still a candidate for an implant? The answer is you are, dependent upon if you can get cleared for surgery. I have some men who want a penile prosthesis, but their heart is too weak and their doctors don't clear them, in which case we have to come up with another option. It's not common, but once in a while we will do surgeries for men in the hospital. So I mentioned to you that most of our surgeries are done outpatient. We do them in our surgery center. But for men who are considered a candidate for the surgery, but it's not necessarily considered as safe to have them operated on in the surgery center, then we can do it in the hospital where there's closer monitoring. There's a question, can STIs cause ED? STI is referring to sexually transmitted infection. Not to my knowledge. They can lead to other complications like scarring in the urethra, for example, but I don't believe that they cause erectile dysfunction. There's a question here, is there an age you don't recommend getting the implant? It's a good question. The answer is no. I think the oldest man that I've ever operated on was 86 years old. I've seen a couple of men in the last few months in their 90s who want an implant. So there's no age restriction. If they can get cleared for surgery and they understand the risks and it's something that they want to pursue, then we would do it. Is there a lower limit for age? I'd say not necessarily. Obviously, men in their 20s or 30s or even 40s, we might want to try the lesser invasive options first. But again, that's a discussion between the patient and the physician. All right, so next, what happens if you get prostate cancer after you've had the implant surgery? Excellent question. So I've had a few patients like this where, I've done an implant on them and then they get subsequently diagnosed with prostate cancer. So in theory, when the surgeon is doing the radical prostatectomy, they can not touch the implant and not have any issues related to it. In fact, I'd say it's pretty rare that the implant gets in the way and part of the device has to be sacrificed. So there are case studies about this. When I was a fellow at Hopkins, I wrote a paper on this. It's definitely possible. What happens when you use the pump and know it doesn't hold the erection? So again, that could be referring to, again, the device breaking down. Again, it's a hydraulic device, so you can have leakage of that fluid that gets transferred that causes the cylinders to inflate. So if that happens, then we examine you, we do testing, we figure out kind of what the problem is. But at the end of the day, if the implant doesn't work and you want to maintain sexual activity, it would mean another surgery to take the old device out, or at least repair the damaged component and replace it. Okay, next comment is again from our patient advocate. Gentlemen, if you want a healthy sex life after prostate cancer, I recommend the implant. Yes, it's different than before the surgery, but you can have a healthy sex life. So thank you very much. I couldn't have said it better myself. Next comment or question, is it common for men under 40 to have ED? It's not uncommon. Probably about 25% of men have some issues even at that young age. In my practice, I have some men in their 20s who have issues. The risk goes up as you get older, but it's not unheard of, certainly even in young age. Okay, Sarah, if you want the other patient champion, that is fine with me to have him up here. Next, oh wait, hang on, give me one moment. Okay, I think I have actually answered all of the questions, at least on the chat. So if anyone has any other questions, now is the time. Otherwise, I very much thank you for your attention. This was a great discussion, very good, well thought out questions. And again, my name is Robert Segal. I'm with Chesapeake Urology. If I or any of my partners can be of help to you, then please let us know.
Okay, my name's Mark O'Shea, and I went through this process of a artificial urinary sphincter and also penile implant. And I also had an issue with Peyronie's. I'm amazed at the number of questions and how informative this discussion has been. My story is simply that I went 10 years seeking some kind of treatment after prostatectomy surgery, unsuccessfully in the Richmond area, including UVA and places like that. And it wasn't until I discovered Chesapeake Urology where it seemed like just a simple assessment, diagnosis, and treatment. So I had both surgeries done at the same time. I was up to 5-6 pads a day, and of course, it was a combination of declining issues with erection and the issues of increasing leakage that just brought me to the point of having a surgery. And I can tell you, just really simply put, it's a life changer. It's a self-esteem changer. It's a 2 weeks ago, I played 4 hours of pickleball. I couldn't have gotten through 20 minutes of tennis or pickleball in the past. I couldn't go hiking. I hike trails now. And it's just been an amazing journey of freedom, self-esteem. By the way, I'm a clinical social worker, licensed clinical social worker in Richmond, Virginia. I work with mental health every day, and what a tremendous boost to my life, my self-esteem, and my sense of self-worth. Just wanted to share that story. I don't know if there's anybody who has any questions for me. I'm trying to figure out how to actually do that, but I saw something jump up.
It's okay, Mark. Robert will ask you if there is anything that comes through.
Okay, thanks, appreciate it. So that's basically the essence of my story, and it's been just a life changer, game changer, and very thankful to Sarah for guiding me in the right direction.
All right, so there you go. Thank you so much, sir. And again, you hear it from actual patients. There you go. There was another question or comment that a patient lost length during the penile implant surgery. Can this be changed? And then prior to the implant, how do you determine the proper size? So again, there are no studies that allude to losing length. We measure the what's called the stretch penile length during surgery. So most of the penile length, believe it or not, is actually inside the body. So when you have, your penis is sticking out of your body, that may only be 40, at most 50% of what the actual length is. So the majority of the length of the penis is actually going to be inside the body. So we measure both the inside the body and the outside the body length, and we sum that together, and that leads to the length of the implant that we choose during the surgery. Okay, another question. What is the threshold for the number of daily depends? So I assume that is referring to how do you decide, if you're going to do the male sling or the artificial sphincter. So that's a very good question. And there isn't an absolute right answer or an absolute cutoff. And there are other things that we kind of factor in. So for example, you may have a man who changes his pad 5 times a day, but he changes it as soon as a drop of urine comes on it, as opposed to a man may wear 2 pads a day, but he's totally drenched. So that's kind of one thing to consider. There are certain tests that we may even do. One of them is actually weighing the pads to determine how much they weigh, which reflects how much urine they've leaked, and use those numbers as part of our decision making. There are other things we look at. So for example, men who leak at night when they're asleep, they may be less helped by the male sling as opposed to the artificial sphincter. There's also, there have been multiple studies that show that men who've had prior radiation do not respond as well to the male sling. And I think part of that, or the main kind of thought to that is the radiation kind of causes the tissue to change in the perineal area, and the tissue is not as mobile, and so you can't kind of reinforce the urethra as well with that mesh. All right, so then the follow-up is, I would be the latter, full 2 to 3 a day, but nothing at night. So you might be kind of borderline. I'd say there might be some guys who, or some surgeons who would recommend the penile, the artificial sphincter. The drawback, of course, with the artificial sphincter is you don't urinate naturally. You have to squeeze this pump whenever you go to the bathroom. That may be a drawback for some men, and they may be willing to kind of accept perhaps the risk of leaking a little bit more at the expense of urinating naturally. There are other men. I saw a patient today who, he told me, or the final kind of decision was, look, I want one surgery.
I guess Dr. Segal is frozen. I'll give him a second to see if he comes back on. He did mention that he might have this issue tonight. So let's give him 1 second.
Sarah, can you hear me? Sarah?
Yep, you're on.
Oh, good. Okay. So yeah, I told you that might happen. I'm glad it only happened towards the end. So what I was saying was, it's a joint decision between the patient and the surgeon. There isn't an absolute right or a wrong answer about whether you do the sling or the sphincter. And again, it's about understanding the patient's goals and their priorities. Let's see. There was another question here. Dr. Eid in Philadelphia induces an erection after anesthesia by injecting the penis to produce an instantaneous erection, which he then measures. That is probably more to measure the body. So that probably, I don't think that will affect deciding how long of an implant to put in, if that helps. Okay. All right. So Sarah's telling me we got to kind of wrap it up here. So again, I appreciate everyone's comments, questions. They were all well thought out, and your attention. Thank you so much, and I wish you a good evening.